Guys, come look at this.
Oi, bro! Kiki, do you think it's okay to cough and then want to go touch a pregnant lady? Are you insane? Do you not wash your hands? Have you so?
Yes, I do.
Then why are you coughing and touching her? Do you think it's okay? Because I don't. You sneeze, now she sneezed, then her cousin sneezed, then the baby sneezed, then her auntie sneezed, then her cousin's only study sneezed. When do you wash your hands?
You have to wash your hands before you see the patient, after you see the patient, after you've written down the two things in the documents, and after you've seen the patient once you leave the room.
Must I show you? Come. It's close to midnight. The doctor sneezed and has to wash his hands. He squirts the bottle into his filthy palms. Then turns it round and washes in between all of these fingers. 2, 3, swap. Starts from the top, then rubs his hands by interlocking fingers. Then does his thumbs. Woo! He washes those thumbs. Swap. And then he washes, wash, baby, wash those thumbs. And then he's journeying. Woo! By scrubbing his nail tips. Scrub, 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 scrub. And then it's jelly. Woo! Jelly time. He puts his hand into a circle and scrubs into his palms. And then he air dries. Woo! Let it go.
So Jessie, as you know, we're going to be doing an abdominal examination now. Can I ask you, can you please perform the focus general examination? So as you walked in, can you just start the examination, and then I'm going to hand over to you once I've greeted him. Is that fine?
Yes, that's fine.
Thank
so
you very
when
much.
he comes through the door, the first things I would check for any illness or distress on his face, his gait, the way he's walking, if there are any signs of pain or discomfort, to check if he's malnourished or if there's any muscle weakness, to check for obesity, and also check if he's guarding his body anyway.
Perfect.
Okay.
Thank you very much. You ready? Good afternoon, sir. How are you?
I'm good, and yourself?
Good, thanks. My name is Glen Thatcher, and I'll be here facilitating this clinical session. Is that fine?
That's fine.
Please come inside. Just going to take a seat. So as you know, this is going to be a clinical session where we're going to be teaching some of the students. Is it all right if all the students examine you?
That's fine with me. Yes.
Perfect. This is Jessie, and she's going to take over from here.
So I see that there's good lighting and the patient appears to be healthy with no signs of any physical distress on first impression. Would you mind taking your shirt off for me? Okay.
I'll take it for you. Thank you.
Thank you. So the skin, I'm going to first check your skin. Is that okay?
That's fine.
Okay, there appears to be no striae, no scarring, a little bit of redness here, but that's fine. Normal hair distribution, that's all okay. Is it okay if I check for any muscle weakness?
That's
Is that
fine.
fine? Okay. That's okay. There's no signs of xanthelasma in the eyes, so that's okay. Would you mind showing me your hands like this? Okay, no sign of distal phalangeal joint pain. Okay, palms up for me. Okay. So there are no signs of faint palmar lines, which indicates no signs of anemia. There's no palmar erythema. Palms are a bit red, but not too red to indicate any of that. Everything is fine. Thank you. Your name's for leukonychia, which is white or opaque nails, which is a sign of hyperalbuminemia or chronic liver disease. So your nails appear to be fine. The putatin's contracture, which is the thickening or contraction of palmar fascia, which you can mostly see on the ring finger. So I'm just going to check for that. That's fine. Can I please see your other ring finger? That's okay. Thank you.
Can each of the students please just introduce themselves to the patient?
Hi, my name is Hoeyaam Allie.
Hi, I'm Adele Meyer.
Hi, I'm Melissa Littlefield.
Hi, I'm Jessie Brand.
Hi, I'm Maryam Patel.
Hi, I'm Firdaus Gallant. Hello, I'm Zilulutho Msikinya.
Hi, I'm Aneeqah Jamalie.
Hi, I'm Gcina.
Hi, I'm Mogammad, Khidr, Salaam.
Hi, I'm Viviers.
Now students, just before we start this examination, can anyone volunteer, or would anyone like to volunteer to tell us the appropriate conditions that this specific exam should be performed under?
I can do that.
Oh, thank you, Lulu.
Okay. Sure. So typically before we perform any abdominal examination, you need to know the processes that go into performing this exam. So the steps are inspection, palpation, percussion, and auscultation. In an acute case, we need to present the examination in a different order. So we do the inspection, the auscultation, the palpation, and the percussion. But before we do all of that, we need to make sure that the patient is lying straight down on the bed with a pillow under his head. His neck, chest, and abdomen need to be exposed with his hands on the side of his bed. This is to ensure that his abdominal muscles are relaxed during the examination. And before we do that, we also need to make sure that he's not experiencing any pain. So, sir, are you experiencing pain?
No.
Okay, that's great. But in the case that he was experiencing pain, we'd make sure that we palpate away from that region. And then that's everything. But before that, we just need to make sure that the lighting is good, which I think it is.
Now everyone, as you know, there's different areas and landmarks on the GIT. Would any of you like to volunteer to show us those different areas?
So your four quadrants, main quadrants are your right lower quadrant, your right upper quadrant, your left upper quadrant, and your left lower quadrant. Another landmark is your 9 regions. It is divided vertically by your two midclavicular lines and horizontally by your transpyloric plane and your transtubular plane. Your first 3 is called your right hypochondrium and your left hypochondrium, and in the middle is called your epigastric region. The next 3 is called your right lumbar region, left lumbar region, and in the middle it's called your umbilical region. And your last 3 is called your right iliac fossa, left iliac fossa, and in the middle is called your hypogastrium.
Hi students, would anyone like to please demonstrate the examinations for jaundice, anemia, and clubbing first?
Can I do it, please?
Thank you, Maryam.
Hi sir, can I please examine your eyes?
Yes, ma'am.
Okay, thank you. Can you please open your eyes for me? Can you look up please? Okay, so we can see that the sclera has no yellow color, so there's no jaundice present, and also the conjunctiva is not pale, so there's definitely no anemia present either. For me, these mucosal membranes are normal color, so there's no jaundice present, and also the patient seems to have good oral hygiene. Bad oral hygiene would have been a risk factor for liver abscesses. So can I please take a look at your hands? Your nails seem to be a good color, it's not pale, so there's no sign of anemia. Your arm also over here has a good color and it's not pale, so there's no sign of anemia. And also your palms, the palmar lines are a good color and not pale, so there's no sign of anemia in you. So can you please perform Shamross test so that we can test for clubbing with your thumbs first? Okay, so there's a beautiful diamond shape over there. Had that diamond shape been absent in all 10 digits, we would have tested positive for clubbing in this patient. Thank you.
Aneeqah, can you please demonstrate to us cyanosis, edema, and lymphadenopathy?
Okay. Sir, can I ask you to please sit up? As you can see, the tips of his fingers do not appear blue, so there's no sign of peripheral cyanosis. Can you open your mouth and lift your tongue up like this? The bottom of his tongue is not blue, so there's no sign of central cyanosis. Now we are going to, can I take off your socks?
Yes, ma'am.
Now we are going to check his ankles for edema. As you can see, his skin bounced back quickly, so there's no fluid retention or fluid accumulation in his ankles. Thank you, sir. And now we're going to check his sacrum for edema as well. No signs of sacral edema as well. Sir, now I'm going to check your neck for lymph node enlargement known as lymphadenopathy. Okay. Preauricular, postauricular, occipital, tonsillar, submandibular, submental, superficial clavicular chain, posterior clavicular chain. So can you look to the left please? Deep clavicular chain, and to the right, deep clavicular chain, supraclavicular. Thank you, sir. You have no signs of edema, cyanosis, or lymphadenopathy. Thank you, sir. You may lie back down.
Thank you very, very much. So students, now that we've done the focus general examination, we've gone through Jackal, the patient is positioned properly. Now we're going to start with the actual examination. So our first step is inspection. I'll be demonstrating inspection for you, and then I'll hand over as we go along, and I'll let you demonstrate the rest of the steps. So for inspection, these steps have been covered already, but once again, we'll start looking at the skin. So sir, may I please just have a look at your skin? So what you're doing is you're just going to be looking at the skin for any discoloration. If it's pale, you're going to be checking for color, scars, even hair distribution, like all of you have mentioned already. Then you'll be looking at the umbilicus, and what's going to be happening with the umbilicus, you're going to check general shape. If there's any inflammation, you can see if it's pointing upward, a downward pointing umbilicus is indicative of ascites, while upward pointing one, and not in this case because he's not female, would be indicative of pregnancy. If it were inverted, there would be possible obesity, but as you can see, the patient is quite lean. The next step would be shape, so then you just come to the base of the bed and just examine the GIT from a distance, just checking that everything's symmetrical, seeing if you can spot any pulsations from the aortic region, the renal region, and then your iliac region, checking if you can see any pulsations. Then you'd come around and start. I'd usually be on the right side of the bed, but now you're looking to see if you can see any peristaltic movements. So now I'm going to have to ask the patient just to lift his head towards his chest and to cough, cough again. And the reason why we're doing that is to check for any herniation. So if it was herniated, something would pop out and then it would stay there for a while and then maybe go back. So as you all saw, there's no herniation in the patient. So I'm going to come back around this way quickly. So what I was checking when I stood here is if there's any symmetry. So there doesn't seem to be any enlarged organs from what I can see, but we'll inspect that later with palpation as well. So with that, there's no nodules, bumps, one side is bigger than the other, so it's quite symmetrical. If the abdomen was distended, who can tell me some causes of distension in the abdomen?
I can. Okay, there are 7 Fs, which are the 7 most common things that will cause a distended abdomen. These 7 are fat, fluid, fetus, flatulence or flatus, phantom pregnancies, fibroids, and feces. Now, fat is obviously, when a patient is fat, they've got fat cells, lipid deposits. Then fluid accumulation from drinking a lot of water, or if there's gastrointestinal problems or bladder issues, so it stays in the body. A fetus would mean if you were pregnant, if he were female and she were pregnant. Flatulence or flatus would be carbonated drinks and lactose intolerance that causes a buildup of gas in the body. Fibroids are also more for females than males. They are non-cancerous growths that occur in the uterus around childbearing age. And phantom pregnancy, which would mean they have all the normal signs of pregnancy, but there's just no fetus. This is very often a psychological thing. And then feces, which are a buildup of those from constipation.
So students, as you know, the second step in the abdominal examination is palpation. Would anyone like to demonstrate a light palpation first?
I would.
Thank you, Hoeyaam.
So basically what we're going to be looking for now is any guarding tenderness, rebound tenderness. We're also going to be looking for any fluid and then also superficial masses. May I start?
Yes, ma'am.
Okay. Start at the right iliac fossa, going up towards the ascending colon. While we do this, we will look at the patient's face to make sure they're not in any discomfort. Hepatic flexure, transverse colon, splenic flexure, descending colon, sigmoid colon, hypogastric region, periumbilical region, and then your epigastric region. Okay, thank you, sir.
So now it's time to move on to a deep palpation. Would anyone like to volunteer to show us a deep palpation?
Okay.
Thank you, Melissa.
Hello, sir. So basically, I'm just going to repeat the previous procedure, but this time apply more pressure by placing my left hand on top of my right hand and pressing to a depth of 3 to 4 centimeters. And whilst I do this, please tell me if you feel any discomfort. Okay. So I'm going to start in the right iliac fossa, then move to the ascending colon. And whilst you do this, look at your patient's face to see if they're making any discomfort. I'm going to your hepatic flexure, to your transverse colon, to your splenic flexure, to your descending colon, to your sigmoid colon, to your hypogastric region, to your periumbilical region, and lastly to your epigastric region.
Okay, students, so the final part of palpation of the abdominal examination is trying to palpate for the liver and the spleen. So, would anyone like to volunteer to do that?
Yes, I would.
Thank you, Khidr.
Hello, sir. Do you have any abdominal discomfort?
No.
Okay. So I'm gonna be touching your abdomen and pressing through it. Is that okay with you?
That's fine.
Okay. So I'm gonna start palpating the liver. You start palpating the liver at the lower right quadrant, at the iliac fossa region. You keep your hands in such a way that this part is parallel to the right lower costal margin and this part is parallel to the rectus abdominis. So I'm gonna start palpating now. Can you breathe in for me? Out, breathe in, out, breathe in. Oh, so I can feel your liver. Your liver is soft, tender, and regular. So the reason I was doing this was to check for any enlargement of the liver or any palms through this region.
Okay, perfect.
So the spleen enlarges inferiorly and medially to the umbilicus. So when you're palpating, you need to put your hands below the umbilicus and parallel to the left lower costal margin. So now I will start palpating. Say, could you breathe in for me? Out. In. Out. Okay, so I couldn't feel your spleen. For the spleen to be felt, it must be 3 times larger than its normal size.
Hi, Mr. Perfray. I'm Adele. Is it fine if I percuss for your liver and spleen?
Yes, that's fine.
Okay. The percussion technique is used to determine the normal span of the liver. Usually the normal span of the liver is less than 12.5 centimeters, and the upper border of the liver is usually located at the 6th rib in the right mid-clavicular line. So to find the upper border of the liver, you must first find the sternal notch, so that you can find the sternal angle, and then you find the second intercostal space, and you start percussing from there, and you percuss from the second intercostal space down the right mid-clavicular line. Resonant in the second intercostal space. Resonant in the third intercostal space. Resonant in the fourth intercostal space. Resonant. This is resonant, and therefore you can hear that this is dull, and this is in the 6th intercostal space. So you mark this point so that you can remember the point of the upper border of the liver. To percuss for the lower border of the liver, you start at the right iliac region and you percuss up the right midclavicular line. Resonant, 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 and that's dull. So that indicates the lower border of the liver, and this indicates the measurement of the liver is less than 12.5 centimeters, which indicates that it is not an enlarged liver. Okay, to percuss for the spleen, you must also start in the right iliac region, and you must percuss diagonally towards and past the umbilicus. Resonant, 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 resonant. Okay, if the percussion doesn't change from resonant to dull, it indicates that there is no splenomegaly, because the spleen usually enlarges towards the umbilicus.
In the case of an acute abdomen, we would have put the auscultation second. Why is that?
You do this because you don't want to disrupt the normal bowel movements, which would be disrupted as a result of palpating.
And percussing.
And percussing, yeah.
Because you answered so well, would you like to demonstrate the auscultation for us?
Yes, I would.
That would be awesome. Thank you.
Hello, Mr. Firthray. I will be auscultating your abdomen, which means that I will be using my stethoscope to listen to the normal gurgling, bubbling sounds of your abdomen region. So my earpieces are away from me. My diaphragm is working. I will start in your right lower quadrant, moving up to your right upper quadrant, moving across to your left upper quadrant, and down to your left lower quadrant. All seems to be in order. If I did not hear normal peristaltic movement, I would have to listen for a period of 3 minutes, and if I heard no movement, I would suspect a paralytic ileus. Thank you, Mr. Firthray, for your time. I hope that you enjoy the rest of your day, and you may now go home.